guys about endometrial hyperplasia. So what actually can happen in endometrial hyperplasia is that few exam questions they can be asked in the exam. So just have an example of this exam question, that a 60-year-old patient presented with postmenopausal bleeding. Endometrial biopsy shows hyperplasia without atypia, and what is the best plan of management for her. So whenever they are giving you exam question, they will ask you two questions, that it is with atypia, okay, or it is without atypia, and then you have to further plan the management of that patient accordingly. So here actually, as this is endometrial hyperplasia and it is without atypia, so the management of this patient, first line can be intrauterine system, okay, levonorgestrel intrauterine system. If the patient refuses or she is not willing, then you can go for oral progestogens. So this can be first line and this can be second line in these scenarios. So here basically the answer would be Mirena, that you have to go for Mirena, levonorgestrel intrauterine system. Okay, so this is basically the chart or flow chart of endometrial hyperplasia, that it can be endometrial hyperplasia without atypia, or it can be endometrial hyperplasia atypical hyperplasia, or you can say with atypia. Okay, so when it is endometrial hyperplasia without atypia, the first line management is levonorgestrel intrauterine system, which is your exam question. The second line is oral progestogens. Okay, so the patients who are having atypical hyperplasia with atypia, the definitive treatment is total abdominal hysterectomy and bilateral salpingo-oophorectomy. Oophorectomy would depend upon the risk factors of the patient as well as her family history. Then you will decide that whether you have to conserve the ovaries or you have to remove the ovaries. But there can be certain situations that the family of the patient is not complete, but she is having atypical hyperplasia. So if the fertility is required or the surgery is contraindicated, then for these patients, you can go for levonorgestrel intrauterine system or you can go for oral progestogens. And then the follow-up of these patients is very, very important. So if it is endometrial hyperplasia without atypia, it would be 6 monthly endometrial biopsy for the follow-up. And if this is atypical hyperplasia, that would be 3 monthly biopsy in these patients. The reason is that endometrial hyperplasia without atypia, it is less than 5% chances of malignancy that it can be converted to the malignancy. But in case of atypical hyperplasia, the chances of malignancy are higher. Okay, so once you are doing the follow-up without atypia 6 monthly and with atypia 3 monthly follow-ups as you are doing, so there can be three situations. Either it can be regression of the disease, it can be persistence of the disease, or it can be progression of the disease. If it has regressed, you will see that if it is levonorgestrel, you can continue for 5 years. Okay, if it is oral progestogens, you can stop after 6 months, or you can advise the patient for total abdominal hysterectomy, and depending upon the situation you will decide about the oophorectomy, okay, bilateral salpingo oophorectomy, if the symptoms are not resolved. And the follow-up of these patients where it has regressed, basically in case of endometrial hyperplasia, you have to see the BMI of the patient, as it is obesity is a risk factor for endometrial CA. Okay, so if BMI is less than 35 and two biopsies are negative, you can discharge the patient. But if the BMI of the patient is equal to or more than 35 and two biopsies are negative, you will not discharge the patient, and then it would be annual review by endometrial biopsy. Okay, here it is a difference of BMI. Then if it is atypical hyperplasia, when the two consecutive biopsies are negative, okay, which you are doing the follow-up at 3 monthly interval, you will keep them on the 6 to 12 monthly endometrial biopsy and review. If it persists, then you have to first check the compliance of the medication if she is on oral progestogens. Okay, So either if it is persisting, you can advise the patient THBSO, or you can see the compliance, that what actually is the compliance of the medical treatment. If there is any progression from endometrial hyperplasia without atypia to endometrial hyperplasia with atypia, then you will advise your patient total abdominal hysterectomy, and depending upon the situation, bilateral salpingo oophorectomy. If endometrial hyperplasia with atypia has converted to endometrial CA, then the management of this would be according to the local cancer guidelines. Okay, so this is very important, that actually endometrial hyperplasia with atypia, without atypia, if it is without with atypia, and if the fertility wish is there, so once biopsy, one biopsy would be negative, you will advise the patient to go for artificial reproductive techniques and complete the family. Once the family is complete, she can go for TH, and depending upon the situation, BSO. And if it is endometrial hyperplasia without atypia, first line is levonorgestrel, second line is oral progestogen. Follow up is on 6 monthly basis. I hope this would be helpful for all of you. I wish you all the very best for your upcoming exam. Have a great day.